Good morning. Can everyone hear me? I usually talk really loud, so it shouldn't be a problem. I was lucky enough to get voluntold to be put on this committee, and I also wanted to know what prize I lost, because I must have done something wrong to get put on it. But I was actually one of the clinical managers in our branch that every single day was chasing face-to-face along with probably 5 other people, hoping to get them checked in so that we could bill for them, so I didn't get another report that told me I had this many outstanding. So when they said this was to help improve the process, I was all about it because I felt like I spent a lot of my day chasing face-to-face forms. From the branch side, when we started looking at this process, we decided to really focus on the community physicians. We have a lot of hospitalists who don't even realize they're sending patients to home health. They're like, oh, someone else makes those decisions. So getting them to write a face-to-face, yeah, that was like an act of Congress, and we know how that works. So from the branch side, again, our physicians, we want to work with the community. Our goal was to improve our communication with them and also get the information to them in a timely manner. Of course, our challenge, though, was getting to have a physician write more information for us. Yeah, that's easy, no problem. So that led us to implementing the process to help them with the face-to-face documentation. We implemented this new process at all branches. We have a written process for both the branches and the physician offices. For, again, our hospitalists, their focus is patients in the hospitals. They are not following them in home health, so we really went to those community physicians who will be following them throughout our home health episode. When we receive a referral from the hospital, we complete a welcome call to all our patients. Once a patient agrees to home health, we call the physician office. We notify them that the referral was received from a facility. We verify they're willing to sign our home health orders, and then we follow up with when the date of their follow-up appointment is. We let them know we'll be faxing information over to them 2 to 3 days prior to the appointment, informing them regarding the patient's condition and home health services. A SOAP note. Our form of communication is a SOAP note. Anyone who's not aware of a SOAP note, it's for subjective, objective, assessment, and plan. SOAP notes make it easier for other healthcare members to understand and care for patients more effectively because it's a standard way to document. We also felt that a SOAP note includes everything needed to satisfy the information for a complete face-to-face. Our therapists had been using SOAP notes as part of their assessment and visit notes for over a year at our agencies. We had an education session for all our nurses in regarding to writing appropriate SOAP notes because it was new for them. We also made every nurse complete a SOAP note for a specific case study to determine their competency. The start of care clinician writes a SOAP note. This SOAP note is then on our plan of care. It's sent to the MD, and it is under the section supporting documentation for home health eligibility. This same note then is faxed to the doctor 2 to 3 days prior to the follow-up appointment. The information is about the patient's status in the home health services the patient receives. This information is to help the MD complete his follow-up and face-to-face encounter appointment. Once the appointment has happened, we either verify it through our electronic medical record. Being part of Carolinas, we have access to the physician's records if they're in our system, or we'll make a phone call to the physician to make sure the appointment has happened. If we actually receive a referral from an MD office and not the hospital, we request that the doctor fax over his visit note from that day. This is actually the fax cover sheet that we send to every single doctor, and it's truly just about the face-to-face. We have spoken to some doctors' offices to make sure the wording will not hit the shredder or not just get scanned into the electronic medical record, because that's what was happening in the beginning. So we tried to make this as plain as could be to just please hand this to the doctor before the appointment so that he can use the information. This actually, of course, is what a SOAP note looks like. And again, it's on like the last page of the plan of care, but we only fax over that SOAP note information to the doctor. And once we have shown some doctors are like, oh, now I get it. Now I know what I'm writing. It's just to help facilitate the communication. We looked at some of our metrics. So what we're doing is collecting baseline data. Each clinical manager is reviewing the physician office face-to-face visit note. If the referral, again, is from the office, we request it be sent over, and we're scanning it into our electronic medical record. If the face-to-face appointment or visit is after the start of care and the physician is part of CHS, we'll look in the patient's electronic medical record to review the note. Each branch manager is looking for the documentation in the office visit that addresses the need for home health, disciplines needed and why, medical condition for home health, and of course, reason patient is homebound. They are compiling the data and sending it to operations weekly. We are looking for trends to see if there's certain areas that the MDs are having issues with, or if there's certain MDs that are not documenting what is required to help us focus our future and ongoing education. Which leads to Kimber.
So, have we figured out the whole problem and everybody is doing what they need to do? Well, not exactly. But what we have learned from this process is we actually reduced our claims held, which is a good thing, from $750,000 when we started down to $57,000. And during that time, that 6 months, we did have to write off some, but we only wrote off $45,000 compared to $300,000 last year. So we're feeling pretty good about that. We've also estimated that we will save the offices, actually in Dr. Kelling's office, because of handling all of those faxes. Not that they did a lot with them, they shredded most of them, but save them about 20 minutes a week just in saving. Now that's something you can go and talk to a physician office about. We've also figured out that we save ourselves about 20 minutes a week per physician practice in our operations from not having to track this down over and over and over again. The collaboration between the Home Health Agency and Palmetto has been incredible. Just the ability to be able to, as we were going through this pilot, send Dr. Kelling's information and say, is this good? Is this what we're looking? Is this what you want? Was really, really helpful, and to be able to get back that feedback. We improved tremendously the understanding of what goes on in the physician's offices, because honestly, we didn't know and they didn't know. And we've even gotten a great deal more support with our system physician offices, including we are working on and developing today the 2 electronic forms of documentation with the physician offices, so they will be able to do this without having 25 pieces of paper. So in the process, what did we learn? Well, here were our problems. There was a tremendous lack of communication between the stakeholders, even internally. And Annette and Kathy talked about this, and I think a lot of us found this to be the case. With all of those people in the room, it was really interesting to find out how many people were touching face-to-face and how many people didn't know the other one was touching face-to-face and what they were trying to do with it. It led to misunderstanding, hostility, and a lot of silo processing or problem solving. I think what we found was every department was trying to fix the problem in their department and never looked at it overall and said, well, if we fix it up here, really, we won't have to fix it back here. We spent more time on cleanup than getting it right in the front, and multiple people were handling the documents. We now have various teams in the same room led to an understanding and a global problem solving. You heard Lynn say, I'm one practice, but there's a lot of others out there. She's taken it upon herself. No one is asking her. She's taken it upon herself to work with the hospital in her area and the hospitalists. That was not anything that we asked her to do, but she recognized that this problem is bigger than just her office and is taking it on and kind of spreading the word. Having the value stream laid out made it easier for everyone to understand the processes and how they needed to be addressed. So even when the rule changed, we recognized we didn't want to go back to where we were. Where do we need to change? We don't all need to change. We don't all need to change the process. Where specifically, so we were able to accomplish and make some of the changes more surgically rather than this overall. And centralized coordination really reduced the frustration and the time that we spent. So what are our messages on a supply change? Get it right the first time. That means everybody must clearly understand what their role is in the process. If we're all making it up as we go along, we will all be doing the very best we can and duplicating over and over and over. Home health operational gains can be made without physician input and participation, But if you want to get it right, you got to include physicians. They have to have input, understanding, and support from everybody on the supply chain, including those physicians. Physicians, while willing to comply, don't understand what is being asked. We know that. But what we found is they were generally very willing once they understood it. And the process for physicians has to be flexible enough to meet their workflow. There is no one way. Each practice operates differently, and we have to be able to provide them with multiple ways of doing it. Questions?
Do you have the issue with, from the system and having to chase down who's going to be the following physician?
Yes, we do. The question is, do we have any problems in the system as to who's going to be the following physician? And yes, we do, and that is one thing we have. One of the things that you'll notice on our board, we have an electronic referral form, and one of the challenges or opportunities was, I know we all have to say opportunities, right? One of the headaches was that the referral form, we trained everyone to give us the PCP, but that really wasn't the following physician. So we've now added to the referral form who is the following physician, and we're trying to educate at that level, as well as our own intake, is who is going to follow this patient. And we bounce it back if we don't have a following physician. It's not easy. We have a greater opportunity with our community benefit / charity, because as part of the system, of course, we're committed to taking all of those patients. And those patients tend to be the ones that don't have a physician. And so we have to work with them on that. The system's trying to, because the systems now are much more interested in readmissions and length of stay, we are able to get a little bit more of their attention on that by pushing it back and not necessarily taking that referral immediately.
And how do you connect that with the hospitalists or intensivists that are seeing the patient, but then the patient goes up, you don't have that connection to a following patient? What's happening with your face-to-face there?
Right. The question is, what happens when the intensivist or the hospitalist is seeing the patient and there is no following physician? We don't take them if we can't find a following physician. We will not take that patient. Did that go over really well at the hospital? No. But it was one of those things that we had to draw a line in the sand. But on that one, we really were able to talk to them about patient care. It wasn't about face-to-face. We didn't go face-to-face down that road. We went who is going to take care of this patient, because we can't operate with somebody without somebody being there to support it. So we really focused on the patient care side of that. Yes?
I have a question, just curious about, I'm going to go back a little bit.
Okay.
In the sense that, face-to-face was generated as part of the Affordable Care Act. And it was put into place, originally it should have been 1/1 of 2011. It got extended to 4/1 of 2011. This question is mainly for Lynn. So Lynn, you had been at that practice since 1999. Something was put in place, say 4/1 of 2011. Home health agencies would have been contacting you guys and sending you all these face-to-face forms, whether it was via fax, hand-delivered, so on and so forth. But yet you were clueless as to what was involved. So before home health agencies got to you, and even before Palmetto generated this initiative, had your practice ever received supportive information from CMS?
Yes and no. We knew the basics of what was needed for home health referrals, because we refer a lot of patients because of our elderly population. We knew the basics. Every home health agency in the area, their process was you fax a form. The form had it spelled out. I need to know what their disease processes are. What care do they need? What do you want us to do for them? We filled out the forms. The docs would put the information on there, sign it. The nurses would help them. That was the process. We had minimal information as to digging through the long interpretive guidelines from CMS. We just knew the basics. Home health agencies came and educated us. This is what we're going to do, and this is what you need to do.
Okay, so I guess what I'm thinking about is if you're gonna get it right the first time, because what you said, those 4 things, it seemed to be there was a huge breakdown in the communication channel where a physician practice or individual physician or an acute facility, we all answer to the same big entity, the mothership, which is CMS. And then that information has to be channeled down to each one of us little sub-ships. So I'm just thinking for future initiatives even, if we do take away from one thing from this is little old home health agency trying to beam information maybe to another satellite entity without getting some direct support from the mothership might make it a little more helpful. Because what I'm thinking is, I'm really sorry to say this, I don't know who the Part B MAC is, say for physician practices in your area, but that entity never came and helped you all understand part of this process? Through like...
Okay, I think that there were a couple of important things there. I hear what you're saying. One of the things that was really important to remember is that we weren't really, unless a lot of the home health agencies didn't know we weren't doing it right until it started getting reviewed in the summer of 2013. We thought we were doing it right. So we didn't know for 2 years we were doing it wrong. So, okay, I think that is where a lot of us kind of jumped up and down and went, okay, we've been doing it wrong for a lot of years, and we knew kind of the basic stuff, so we couldn't fix we couldn't help the physicians because we all had written documents, we all interpreted it one way, and we didn't know. Okay. I think the other thing is that there's a lot of documentation that goes out to the physicians. One of the great things about this project and working with Lynn and my ability now to start working with more physicians, and you'll have the opportunity to hear more, is we were operating in a silo. We didn't know that Lynn kept shredding those faxes. I mean, I literally was like, you did what?
I said, we did it once. I'm done with it.
She thought that when we were sending it, even though we were saying, no, this isn't exactly right, she thought it was the same thing that we had sent 2 days ago. Well, it was the same patient. Right. So she was like, okay, done that. And I can tell you, having the opportunity to talk to other physician offices, they don't know. And you really, I mean, this is what we've faced. We've thought for all of these years, they kind of get it. They kind of don't get it at all.
No, well, and that's what I'm thinking. So this is just probably a global. I've had plenty of other physicians' offices are thinking it was just duplicate paperwork and not realizing, well, we're sending it back because it has to be written in a narrative statement. Right.
Yeah, I just wanted to make a quick comment. And by the way, that was an excellent question, and that's the type of feedback that we need. Part of our goal with respect to this initiative is we are gathering data on all of the initiatives, and we're doing different flavors of this OPICP with physicians, with hospitalists, as well as the home health agencies. That's one of the reasons why we have the home health max here, because we want to nationalize this, and we want to provide that feedback back to CMS so that we can work together from top to bottom to try to get this right. And so, honestly, that's a great question. I understand, again, that sometimes there's frustration with the changing regulations year after year from quote-unquote the mothership. But again, we can't get it right until we work all together, and that's the important feedback and the data analysis that will occur over the next months, possibly year and a half, that we will be reporting back to CMS. And trust me, we will be reporting these initiatives as well as that feedback to CMS. So be assured that CMS will get the message. We get the message as Max. Our brethren, CGS, NGS, the other home health MACs get it, and we will be collaborating with the AB MACs nationally to get this done right. So.